Hello and welcome to the VJ Hemonc podcast. Today we will be focusing on novel strategies and advances in the management and classification of myelodysplastic syndromes, featuring conversations from the third international workshop on MDS and MPNs. First, you will hear from Uma Borate, Luca Lanino, Robert Hasserjian and Zoey Xie, who share updates in the classification and restratification of MDS. They first discuss changes that have been made in disease prognostication and also comment on the potential of using artificial intelligence to aid clinicians. The experts also share insights into the precursor conditions, CHIP and CCUS. This podcast is part of the MDS channel on VJ Hemonc, which is supported by Geron. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only.
We just had a wonderful session talking about classification, prognostication, eligibility criteria in MDS, CHIP, and CCUS. And I have a wonderful panel of discussants, and I'll let them introduce themselves.
I'm Robert Hasserjian. I'm a hematopathologist, and I work at Mass General Hospital in Boston, Massachusetts.
My name is Zoey Xie. I'm from Moffitt. I work for myeloid diseases, particularly focused on CHIP and CCUS.
Hello, my name is Luca Lanino. I'm a hematologist, now serving as a postdoc at Yale University in New Haven, Connecticut.
And I'm Dr. Uma Borate. I work at The Ohio State, and I take care of patients with MDS, early precursor disease, and AML. So I'd like to start the discussion just maybe starting with Dr. Hasserjian, and you had a wonderful talk about sort of you highlighted the difference between sort of prognostication, classification, and then you really brought home the changes that have occurred so far and where you see the field is going. So I know you had a 10-minute talk, but maybe you can compress that in 30 seconds and kind of give us your view on that.
Yeah, sure. So I'm a hematopathologist, and I focus on disease classification. And in MDS, the idea of this was to develop different disease groups of patients that had different features, which initially was the way things looked to us pathologists under the microscope. But as we've increasingly learned about the genetics of disease, we realize that many aspects of disease are driven by the sort of aspects of the disease that are sort of stitched into the genome. That is the profile of genetic aberrations and cytogenetic features. And these are now beginning to enter our classifications, defining specific groups. These can inform therapy because they can indicate vulnerabilities based on the particular genetic aspects that can be targeted, which includes some new drugs that have recently been approved. But I think only about a third or a quarter of MDS cases now fall into genetic groups. So I think some new current AI and machine learning informed classifications have emerged that propose classifying all cases in terms of their genetics. I think these need further validation, but I think they're exciting because they can introduce a more objective way of classifying the disease and potentially identifying new genetic targets that may have, in the end, help to benefit patients. And again, I think that moves beyond just risk stratification because it indicates specific disease categories that could help decide what therapies for the clinicians to give the patients.
Wonderful. I'll kick it over to Dr. Lanino and your efforts in sort of harmonizing what has turned out to be a little bit of a tumultuous world in the last few years in MDS. And
very much so. Yeah, thank you. So what we did after the 2022 classification came out as a consortium, as a community for the iwMDS was trying to harmonize, so find some common ground from the two classification. We applied some of the techniques that Dr. Hasserjian just talked about. And we were able to both, validate those new genetic entities that were defined in the 22 classification and also highlight how much work needs to be done, referring to what he was saying just a couple moments ago. I do think that, these newer tools, AI, machine learning, can help us together with, all the lab work, all the bench work. And as we need to find new entities, because what we're lacking right now, that's pretty obvious, as also came up in the discussion, we don't have drugs that work very much.
Mm-hmm. And so maybe to sort of end your discussion, you ended your talk by talking about a sort of a very aspirational vision of what you want this to look like. And you're a young rising star, and maybe when we retire, that vision will come true, or maybe before that. So maybe describe kind of what that aspirational vision.
Yeah, the title of my talk was like a roadmap to harmonized classification in the future. I'm not sure I can devise a roadmap, but I have some suggestion, and I think we now have technology to amass vast amount of data, EHR pretty much everywhere. We have AI models can help us extract information from those without manually annotating all of that. We can put all of those together and hopefully we can extract information to define these new entities. And another thing that I think it's very important is that those results should not come out only as papers. Those should be platforms that anybody in the community can interrogate, can investigate, and hopefully can generate new hypotheses.
I think that's great. And that's so critical for our field. So I'm going to switch gears a little bit and talk to Dr. Xie, who I think did a fantastic job of outlining the challenges of going a little bit earlier, right? Our earlier stages to MDS, which is CCUS and CHIP. And we're all interested, hopefully, in intervening a little bit earlier when patients aren't as sick, but we are struggling in how to do that. And I think your talk really summarized the challenges, but also the opportunities of how to do it. So maybe if you can give a little bit of an overview of what you talked about.
Yeah. So in my talk, I first gave overview of the current and ongoing clinical trials. We can see over the past 8 years that we see a steady rise of the clinical trial activities. However, we find there's a lot of heterogeneities across these trials, including the inclusion criteria, endpoint selections, and the biomarker integrations. And even for the primary endpoint assessment timing is really all over the map. So these are really cause a lot of challenging to interpret the results across the trials. And our goal is really to bring the results to our patients in our practice. And given these challenges, make it so hard to do. So at the end of the session, I provide a kind of try to share a proposed framework and how we can do this better and to standardize this CHIP and CCUS clinical trial design from the both investigator perspective and also from the FDA perspective, and how do we match each other to meet their standard. And eventually, I hope that we have some therapy and bring it to our patients.
It's great.
Yeah.
So maybe we can end this by each of you sharing some thoughts, like specifically for patients. Maybe a patient who's looking up MDS and just been diagnosed is looking up things online, they see this video. Maybe what you can share, just one or two things that you would like a patient with these diseases to know about kind of what your efforts are and where you feel the field is going. So very patient-centered kind of comment, maybe.
Sure, I can start. I think patients should be aware of the disease they have. They have MDS, but also a specific subtype. And I think that could be a genetic subtype. And then I think patients are often following things like the blast count, and that could be a measure of effectiveness of therapies, something additionally applied. So I think patients obviously should also know their risk assessment, the prognosis, but also the specific type of disease they have, because that may help them understand why particular therapies are being given to them.
Great.
And Uma, I really love your question is, patient-centered. I think at Moffitt, I want to bring out, so we have a CHIP clinic similar as you have and other centers have. So this is, I recommend patients who have this condition like a CHIP or CCUS, this patient will be referred to an academic center, have a really comprehensive discussion. What does it mean? What are the implications? And then we as an investigator trying so hard to bring the trial to our patients. So the trials are coming and, hopefully we can, like I said, eventually we can bring this therapy to our patients.
Wonderful.
And one page to know, MDS is a rare disease. Numbers are low. It's difficult to, have progress in the field, but there is a vibrant, active community. iwMDS is one part of this. There's a lot of others. And this community is really moving forward with new advancement. And so there is hope for everybody with a diagnosis of MDS.
Well, I'll end by adding my 2 cents. My talk specifically in this session was really around making sure that we can get more and more MDS patients access to clinical trials. And as a community, as we mentioned here, all of us at this meeting, we're really focused in the end on patients because we want to get newer treatments to patients. And I think all of these efforts are really geared towards that. So just know that there's a lot of us working to hopefully solve the problem of MDS and make your lives better.
Next, we turn to Hetty Carraway and Amy DeZern, who discuss novel pathways and therapeutic agents being explored in MDS. They speak about telomerase inhibition, the importance of biomarkers, the Select MDS-1 study, optimizing the use of luspatercept and elritercept, and protein kinase agonists.
Hi, everyone. My name is Dr. Hetty Carraway. I work at the Cleveland Clinic in Cleveland, Ohio.
And I'm Amy DeZern from Baltimore, Maryland, where I work at Johns Hopkins. And we've just ended a lovely session of novel therapeutics and targets in myelodysplastic syndrome. We started with Dr. Valeria Santini speaking about telomerase inhibition, which I thought was really interesting. What did you think?
I agree. I thought she did a fantastic job reviewing kind of the importance of imetelstat in our patients with low-risk MDS that are highly transfusion dependent. And she kind of walked us through some of the questions that we have in terms of the biomarkers that may not be entirely relevant with those inhibitors. And I thought that was a nice kind of foray also into your talk about the importance of having a biomarker. Your question was specific to her as well about what are we going to use as a biomarker, if any? And it sounded like her thoughts were that we don't quite have one yet for her for imetelstat.
I think what's interesting is there's no question the drug works, right? It's been approved. It raises the hemoglobin in patients who've previously remained transfusion dependent. We know that from the iMERGE trial. And even though it is listed or labeled as a telomerase inhibitor, there's no question that it's an on-target effect, but it's not clear that that's the mechanism through which the hemoglobin is raised. Yeah. And so I think we just really need to see some more studies to better understand how it's actually working. And that may show us which patients it's more suitable for, and in a way be a biomarker. But I do think she was clear that there's really no role for measuring telomerase length a priori.
Right.
So we'll have to figure something else out.
Yeah. It sounds like she's working hard on that.
For sure.
And tell me a little bit or highlights for the group about your study and your talk about RARA.
So we did speak about retinoids specific to the SELECT-MDS-1 trial, which unfortunately was not a trial that ended up with a positive result, as the combination of tamibarotene with azacitidine compared to azacitidine alone had very similar CR rates. But there were some pearls in the data. For one thing, back to the earlier point, it was a biomarker study with a peripheral blood-based assay that was done a priori for eligibility, and it accrued really quite efficiently.
Yep.
We saw that the toxicity was manageable, though a little bit more myelosuppressive, especially more anemia than we had anticipated. But interestingly enough, in the patients who were transfusion dependent at baseline, the combination with tamibarotene and azacitidine led to more transfusion independence compared to azacitidine alone, which kind of begs the question if retinoids would have a role in lower risk MDS. I think we're going to find out if, there's another retinoid out there in a combination trial from China with decitabine that may be published very soon to see what the path forward could be for those other drugs. But certainly very interesting.
Definitely.
You want to tell us sort of what you talked about, thinking of other ways to alleviate anemia?
Yeah, I had the good fortune of talking about luspatercept, of course, which is FDA approved for our patients that are transfusion dependent. And, we highlighted some of the benefits in the TGF-beta pathway for inhibition, including luspatercept as well as elritercept. Both of them seem to be quite effective and have really nice response rates. And the durability seems to be really encouraging in luspatercept, as evidenced by some of the meeting some of the secondary endpoints of the study that was presented by Garcia Monero and at ASH this past year. And, equally important is the elritercept data that also shows really encouraging response rates and really nice durability. So I think there'll be some really interesting questions that emerge with, what are the patient populations that benefit from both of these? Are there subsets, or is it really everybody? And, some of the benefits with the elritercept is really that it's both early and late stages that it has an impact in terms of the erythropoiesis. And so if that really changes things or impacts how patients do, and gosh, that would be really exciting to see improvements in both platelets and neutrophils as well as hemoglobin. So I'm excited about that data.
One thing that I thought was interesting also about elritercept is it may have some other benefits in terms of metabolism, cardiac function, immune system. I think it remains to be seen. That sort of led to a spirited debate at the end of how soon is too soon to start therapy, or what level of depth of hemoglobin do you wait until to start, with the ELEMENT trial starting a bit earlier at a hemoglobin around 9.5. And I think that maybe on either side of the pond, there's a little bit different approach of what the appropriate hemoglobin threshold is, but we're definitely going to learn more.
Yeah, I actually liked the debate. I'm really glad that people are pushing forward to say these agents are well tolerated. And if we have patients that are symptomatic and not meeting criteria of transfusion dependence, why couldn't we start therapy earlier and hopefully improve their quality of life and also potentially the duration of some response and or benefit to them. These diagnoses are really tough on our patient population. And as you well know, many of our patients are elderly and have many comorbidities. And if these agents have an impact on comorbidities like cardiovascular disease, that hopefully that is important, A, for us to measure, and B, important for our patients if there's benefit.
And I think it sort of merged a number of themes that we've heard today and led to the fourth talk in the session with Dr. Zeiden's data on PK agonists and then the Matterhorn trial and roxadustat.
Mm-hmm.
What endpoints we're going to measure, what makes a trial successful if it's designed correctly. But he alluded to the fact that he believed that the drug was still very useful. What did you think about some of that Matterhorn data?
Yeah, so the roxadustat study looks really interesting to me, especially with the subset analysis that then was done in the post hoc setting, where they looked at transfusion independence along with a rise in hemoglobin. And gosh, I wish that was pre-specified rather than post hoc. And so it really does highlight the fact that setting up the study from the beginning is really important to get that right, because perhaps this drug may not move forward as a result of not including some of those right endpoints in the upfront setting. I hope we'll be able to somehow have access to that drug or resurrect it, because it sounds like it has activity. The other things he ended up talking about was the pyruvate kinase pathway, which seems to have some huge strides in the thalassemia space currently, and probably another area of investigation for us to pursue in the future.
Well, and he has a next generation of that as well, looking in a 2A study. So maybe some data we'll see in the relative near term. But I think a lot of fun discussions on novel agents and targets and hopefully just other ways we can find to treat our MDS patients.
Yeah, hoping for the best and looking to the future.
We hope you enjoyed today's episode. Be sure to follow us on X at VJHemonc and subscribe to our podcasts on Spotify, Apple Podcasts, or Podbean so you never miss an episode. Thanks for listening, and we'll see you in next week's podcast.